Oh, that didn't work.
There you go.
Let me just try to see if I can handle this camera. Is that good or is the lighting was bad?
Well, yeah, you're kind of backlit, but I don't know if you can change that.
Let me see. I think that's way too dark, right?
No, that's better.
Oh, it's better. Okay.
Okay.
Sorry, I was on a call. I'm still on a call. I'm finishing. Our meeting is running a little bit longer than I thought it would.
Are you just gonna like take a call in the middle of this?
Pretty much. I'm gonna hang up though. I'm guessing they will finish up without me. I hope they will.
I mean, I guess as long as you're not leading the meeting, you're okay, right?
I'm co-leading the meeting, but
You just hung up.
it's all right. They'll get over it.
Well, I appreciate that you think that this is more important than
This is really important. This is really important. Community and educating the masses is more important than our projects right now, which they are very important too. But
right. Well, I mean, I appreciate that you're doing this because I know because of all of the differences in like information that's been coming out over the past few weeks, like I'm not 100% sure like what to do. I mean, I kind of know what to do, but like the information keeps changing. So I appreciate you coming on and telling us the official word on COVID-19. And then like hopefully in a couple of weeks you'll come on to tell us that you found a vaccine and we can all go out again, right?
exactly, we're working on it. So actually, UPMC is working on research vaccines. So it's going to take a few months though. It's vaccination is vaccine development usually takes 5 to 10 years, but we'll see how fast they can develop this one.
Okay, well, before we get into that, why don't you go ahead and introduce yourself and tell us who or what UPMC is?
Yeah, so I'm Salim. I'm your cousin, of course, for those that didn't know. I am a physician by training. I work as a this camera. Sorry, I'm trying to hold it again. Hold on 1 second. Hold on 1 second. I'm on a live session, but
Oh, I'll talk to you later.
okay.
Yeah, touch base.
Yeah, we'll touch base after this. Thanks. Sorry.
Should I cough so they think that it's like a patient?
Yeah, exactly. Like doing a telemedicine visit. So I am a physician by background. I still practice. Sometimes I was practicing Saturday. Saw a suspected case. Test was pending, so I don't know if she'll end up being positive or not. But anyways, still practice medicine. But my bigger role is VP at University of Pittsburgh Medical Center. We're 41 hospital system, not just in Pennsylvania, but also internationally in Ireland, Italy, Kazakhstan, and others. And I manage 8 of those hospitals. So, helping physicians, helping us in that role. I also lead telemedicine. So I'm the head for telemedicine across both in the hospitals as well as clinics. So we have around 160 clinics and we have around 2,800 docs. So, yeah, so that's sort of my main role.
Okay, and I assume at this point everybody is kind of all hands on deck and trying to work through this regardless of where they are?
Oh, absolutely. Not just all hands on deck. We have been going at this pretty much 100 miles an hour. Start my days, and you've probably seen some of those before around 7 o'clock till usually late in evenings, 8, 9 p.m. So including weekends, and this has been going on for a while now. So.
Yeah, I guess how early did you all kind of realize that this was going to be a problem?
So we had started doing screenings on our patients probably as early as January, but that was just sort of screenings, right, for patients that were coming from China, where it started, and then we started gearing up pretty quickly in February. So, of course, our plan has been evolving, and as you sort of alluded to before, right, it's rapidly changing. So some information that I will share today will be probably outdated right after this live session. That's how quickly it's evolving, and it's a lot. It's a lot to keep up with, just as a physician, as a leader, but also trying to keep up, trying to update the docs and the nurses and everyone else.
Sure. And I mean, you do that like pretty regularly. I think you do like, I guess, not live sessions, but like Zoom meetings and stuff for your doctors and other healthcare workers pretty much every day, it looks like.
Yep. So we have a daily sort of employee-wide updates, but we also have a daily doctor's update that goes out. The doctor's update also includes actually our coronavirus patients that we have in the hospital, as well as the tests that are pending. So PUIs, persons or patients under investigations. So we definitely have daily updates. And besides that, we also do live town hall meetings, essentially what we're doing, except on our secure platforms, so that docs can hop on and ask questions. We had one, the highest one we had was actually a few thousand doctors that logged in. And that's been in the history of the organization. We've never had so many docs hop in. So very hot topic.
Right. Okay. So this is like, I guess, are they mandatory meetings, or are they just like where people can come in if they've got time?
It's people come in when they get time. So like last week we did a ton of. We actually started with weekends, so we started with a Sunday session, and that was pretty popular. And then we started doing 8 p.m. sessions. So guys also have to remember we're still full on schedule, right? So we still have regular patients to see, clinics, etc. And we have to sort of learn on the job, get training on Corona and how it's evolving and what the organization is doing and how the response is. Because sometimes we go above and beyond what CDC might recommend. And I know that's one of the questions you're going to ask me soon. So,
well, let's just get to it. I mean, do you think that the CDC is sufficiently handling this? And in terms of like being a healthcare system, is that even an organization that you all look to, or are you all doing your own thing?
Yeah, so we do look at CDC, what they're recommending, of course, but usually, I don't know if CDC is logged in, and
I don't think they follow me.
and I have to be careful. But we are going above and beyond what CDC is recommending. So in terms of PPE, in terms of protecting our staff, and our recommendations rely on our experts, our internal experts, lot of sort of research, a lot of academia, what we're seeing from other organizations, and then we also use CDC sort of as our sort of foundation, but we don't limit ourselves just to CDC, if that makes any sense.
Sure. You referenced PPE, which is the personal protective equipment, like masks, yep, things like that. Are there enough? Like, does your system have enough, or is this like a nationwide shortage?
Yeah, so there is a nationwide shortage for sure. As you guys probably know, there's a huge supply chain disruption across the world, not just here in US or just in China. China being one of the main sources of supply chain, but Europe, pretty much everybody, Asia, Americas have been disrupted with the supplies that are coming out for a variety of reasons. Number one, China was trying to fight it, so they were not exporting as many items. And then, of course, we're trying to get a ton more supplies than we normally would. So we have, as a large healthcare organization, 41 hospitals, 85,000 employees, we have been able to leverage our supply chains pretty aggressively to secure as much as we can in a sort of search plan preparations, but we clearly don't have enough because we don't know how much we will get hit and how much PPE we'll need to use. So we have some. We'll probably we'll get by, but we don't know how long we'll get by, and we don't know how long this will last. Of course, the smaller hospitals and clinics, they absolutely have nothing. So, on the side, I run a free clinic as well. So I also have a lot of free clinic contacts. So we have a monthly free clinic, and our clinic had access to nothing. So we had to basically convert to only telephonic clinic. And I know a lot of clinics have closed because of not having adequate PPEs. And I know smaller hospitals definitely struggle a lot. And we would struggle as well if we were not part of a large 41 hospital system.
Okay. So is there any chance that the supply chain is going to sort of be back up to consistent levels anytime soon, or is it looking like you all have what you have and you get what you get?
I don't think supply chain is going to get any better anytime soon, just because of the demand. It is looking like China is getting better. China is getting up and sort of running again. But we are still not getting enough. So I'll give an example. Let's say we order 100 boxes of masks. We'll get 1 box. So we're getting something, but we're not getting what we order, or at least the quantities that we order.
Sure. Are like hospitals and clinicians and stuff hoarding these masks, like people are hoarding toilet paper?
Oh, are they hoarding?
Yeah.
So I wouldn't say hoarding, but so much that we do need to have enough stock to at least last us for a few days or even weeks. As you can imagine, we could get a surge of patients, any time. Philly has been hit pretty hard. New York has been hit pretty hard, and we're very, very close to New York. We're only 3 hours to New York, so we're very close to an epicenter. As you've seen what's happening in New York, if something like that, those cases or that level of we would start seeing that level of epidemic here, we would run out very, very quickly. So we do have to have enough stock, and which that's normal sort of operation for any business, right? You got to have enough stock to keep your business running at least for a few days to weeks. So I don't think we're in a hoarding phase. We are in a sort of a stocking as well as conservation phase, which means that we are not just throwing everything away as we would normally. So, and that's again according to the guidelines. So, for example, N95, which has probably been in stories everywhere, is in very tight supply. And N95 is a mask that you don't necessarily need to throw it away after every patient, unless of course it's has fluids or it's like really not usable. Yeah, so as long as it looks okay and looks good, you can use it, or it's not one use item. So we're definitely going we are in a conservation mode.
Okay. So you mentioned the N95 masks. I read somewhere that like California has a bunch of them, but they're expired. How does a mask expire?
So it's the filter that's inside the mask that's probably expired. So regular mask, it's just made of cotton, and that's what you think. Like cotton doesn't really expire, but it's like the filters that are inside that might not filter as much. Yeah, so there's definitely some of those issues as well. And then actually, I should go back to the hoarding. I think there are also people, not healthcare workers, that are trying to hoard N95s. So we've had a tremendous amount of businesses that have come out and have helped donate as well their supplies. So just keeping in mind, N95s aren't the only. Healthcare is not the only sort of place where N95s are used. Construction workers, labs, university labs. Sort of any lab you can think of, biology, chemistry labs, they all use it. Schools, A lot of schools, now that they have shut down, they have come out and tried to offer us their donation of their N95s. Construction's basically all shut down, so a lot of construction sites have, or workers have tried to donate their masks to us. I've seen woodworkers, like people who sort of do woodworking and things like that. It generates a lot of, I guess, sawdust, things like that. So they use it. I didn't know woodworkers used N95, but that's pretty cool. That makes sense. They should be using it. So of course they're hopefully not doing any woodwork right now, but they're coming out and donating. So a lot of people are trying to get a hold of it. You've probably seen a lot of ads going around everywhere trying to sell N95s. So I think a lot of people that don't need a true N95, they're trying to wear N95s on streets and things like that, which is not recommended. They're probably hoarding it.
Okay. And actually, so this kind of leads into my next question, which was that initially I guess the general public was told you don't need a mask of any kind, it's not going to help. But then recently, like within the last few days, I read people should be wearing masks when they're out, maybe not necessarily like an N95 mask, but something to cover their face. So what is kind of like the latest information about that, and why is it changing?
Yeah, so I think it's changing according to what we're seeing in the country and the number of cases. So I think we've seen cases come up significantly. We're over 100,000 now. Overall, I think the world we're at, I think at last I checked was 600, and I'm going to look it up right now, 680,000. I don't know what was the latest number. I don't know if we've reached 700,000 or not. Oh yeah, we have. We passed 700. We're 766. So as you can see, like, and my number was like I just had checked a few hours ago. So we're at 766,000, 153,000. So it's a couple of reasons, and it makes sense. And we knew that was coming. And we've implemented some of those at our hospitals too. So just last week, we weren't asking everyone to be masked. Basically, all nurses, all doctors, for every just walking around in the hospital. I'm not even talking about going into patient room, but now, and you might have seen my story on Saturday. As soon as now we walk in to the hospital, we are being screened. As in, if you have a fever, were you exposed, and then we get a mask and hand sanitizer, and that's a regular mask again, and we are being asked to wear masks just walking around in the hospital. Same thing, sort of CDC's changed their guidelines now that we're seeing, up to 153,000 patients in US. And definitely, if you're somewhere in an area that's epicenter like New York, if you go out, you should probably wear a mask. And probably it's a good idea for a couple of reasons. Is that if we have sort of those asymptomatic patients, you are protecting others from yourself. So if, let's say if a person is asymptomatic and they sneeze or cough, they're really spreading the virus in the air. And if you have a mask on, at least you're not doing that as much. Even though you cover your face by your hand, it's not, as you can see, it's not 100%. It's probably like 20% that it stops the aerosols. But having a mask on will protect from sort of aerosolizing the virus in the air, but also it protects the person as well, because if you notice, we might not notice, but a lot of us touch our face, not even thinking about it. But if you have a mask on, even if you touch your face, you're basically protecting yourself from your own hands and things like that, just not knowing. So, and again, it's not an N95 mask, and probably okay if you're just sitting at home, not going outside. But if you're going outside or you're around people, probably a mask, especially in the areas that are epicenter, it's a good idea, as CDC has recommended now.
And do you expect that to change, or do you think that's going to be around for a
while? Depending on how we look at these cases and how much or how much more we see, I think it will change, but I don't know when.
Okay. All right. and I actually want to go back a little bit, like it seems like we're getting, again, a lot of changing information, but can you tell us why like COVID-19 in the first place is dangerous, why it's not just the flu? I mean, I know some people have asked you if it's I guess a media amplification of a small problem. I mean, what's your sense of it?
Yeah, so it's definitely not the flu, and that's a really excellent question. Because honestly, I was asking the same thing. I'm like, oh, it's young people get it and they're usually fine and they get a mild disease and they get over it. But it's the mortality rate, right? So a regular flu season, our mortality rate is 0.1%, around 0.1%, right? So really low. Um, the data we've seen so far coming out of China is around, in the general population, it's around 1 to 2%. So that alone, that's almost 200% higher mortality than flu. But that's in general population, right? So once you start looking at people at 50 and people above 60, there's some data that shows mortality of reaching to 5% on an age group of 50 and above, and as high as 10 to 15% on those that are age 70 and 80.
Wow.
So you can imagine, right? Like if you're 80 and above, it's 15% mortality compared to 0.1 of flu. That's really severe, and that's sort of across the spectrum, right? Not just not talking about immunocompromised or patients that have other comorbid conditions like diabetes, heart issues, things like that. It's probably even higher in that specific group. And it's just we don't have enough data to sort of specifically find out what the mortality rate is in that group, but it's definitely higher.
Right. Initially people were being told, if you're young, this is not really something that you have to worry about. You're not going to get sick. And we're finding, I guess, in the U.S. that that's not necessarily the case, that more younger people are being hospitalized.
Yep. So that's definitely something to be we're going to be looking at, but a lot more younger people being not just hospitalized, but coming down with severe sort of illness, as in they're in critical care, they're requiring significant amount of oxygen, not just by intubation, which is putting on life support, but we've had to basically prone them, as in put them upside down on their on their belly so that their lungs expand. Some really sick patients and relatively healthy patients that are requiring some significant amount of oxygen to help them breathe. And that's where we're losing a lot of these patients to where they just can't breathe and get oxygen. And that's the other thing too, right? Why this is more severe is not just mortality, is we don't have a vaccine and we really don't have any good treatment for this. And we're probably not going to get any good treatment or vaccine for a little while. All the things that we've seen, the data for everything that's sort of studied, it's really small studies, and it's only in very controlled 5 or 10 patients, so not really statistically significant.
Right.
Which is really scary as doctors when we have no treatment, no vaccine to help these patients.
Right. So do we know yet the difference between in terms of numbers of people who have died, excuse me, who have died specifically because of the disease versus specifically because there's a lack of resources? There's not a ventilator, or they have ventilators, but they're all going to people who are more likely to survive. Do you know what the difference in those numbers are yet?
No, I don't think we have gone at that level. I do know though, at least here in US, we haven't seen that yet. New York is a place where they need more ventilators, but I have not seen, and they're trying to order more ventilators, but I have not seen where people are dying because of access issues. Now, maybe I've seen some cases, and again, it's anecdotal information, is that people have been asked to stay home, so they might have stayed home thinking that they'll get over it, and they're not getting over it, especially, right, if you're young and healthy, you just think you'll get over that.
Mhm.
But they come in and they're pretty sick. Does that make sense? So it's not that
Sure.
because of lack of resources, it's people are staying home perhaps when they shouldn't be staying home and coming to the hospital, basically. So I mean, they should stay home, but when they're sick, they should come seek care.
And so when it seems like that is a different recommendation based on like where you live, even like here in Kentucky, they're saying, or the governor is saying, if you're sick and you might have it, stay home unless you have like I guess like breathing problems. If you just
Right.
have fever, stay home. Is that true across the board, or is it kind of like governor to governor who's recommending whether you go to the hospital or not?
Yeah, and so that's generally true. So if if you don't have significant symptoms like really high fever that's not going down, or you're having trouble breathing, then you should definitely seek care. Or you're just not feeling, you're just really sick. If your symptoms are mild, where you're breathing fine, you don't feel out of breath, you don't have like a really high grade fever, and I'd say high grade fever as in like 102 or and above, or your fever doesn't go down after you take Tylenol or Motrin or things like that, you should definitely seek advice. And people can start with telemedicine, and we've put out a lot of access points to access us, so that patients don't really have to bother to even leave home, but at least they get to see a doc and get some advice. And that's a huge area of passion that's for me, as well as right now where this is in really hot demand. So our numbers, so telemedicine visits last week, we went up over almost 900%. So a lot of people are seeking care that way, which is great, right? Because patients are staying home, and we want them to stay home when they can. And then there are there are cases where when we see them and we say, "Oh wow, you're looking really bad. You need to come into the hospital, or you need to come into the clinic." Then we ask the patients to come in, but it gives them another access point to get seen. And if they're bad, they come in.
Okay. Do most, I guess, is like the telemedicine usually through your insurance company, or is it usually through like your doctor?
Both. So we're definitely seeing more of a sort of conversion towards more with your doctors. So we offer telemedicine for both sort of primary care specialist, your sort of urgent care type stuff. So right now, if you want to see any doctor, whether it's cardiologist, pulmonologist, OB, cancer, so oncology, genetic counselors, we're about to go live soon. So really any doctor that you can think of, you almost have ability to see them online via telemedicine, which is really great.
Right. So you mentioned people who are asymptomatic, meaning that they're not showing any symptoms. So I've been hearing a lot about this. If you're asymptomatic, does that mean that you're asymptomatic for like a couple of weeks and then you're going to show symptoms, or you might always have it but never show any symptoms?
Yeah, that's an excellent question, and it depends. I wish there was a straight answer. I think it depends on the immune system, on the patient's immune system and how healthy they are. At best, they might get mild symptoms, so mild cough, and sort of a mild viral illness, and they just probably just account it to a regular viral illness, and that's sort of that's all they get. It's 14 days is the incubation period from the time that you get exposed. And again, this is all sort of right. It's not perfect science yet, because this is what we've seen. I've seen incubation, I've heard of incubation as high as 21 days, but 14 days is generally accurate. So, if you got exposed to someone and you don't develop symptoms in 14 days, then more than likely you're not going to get symptoms, or you basically didn't get are not going to get the disease, if that makes any sense.
Okay, but you can still spread it, obviously.
Yeah, you could get exposed again, right? So I got exposed, let's say, for example, I get exposed 2 weeks ago. I didn't develop any symptoms for 2 weeks, but I might get exposed to someone again tomorrow, and then my 14 days starts again.
Okay. I'm using this new little question feature, and so people can see some of the questions that are coming in. So this is an interesting question. Is it true that COVID-19 is reoccurring like herpes? It never goes away and can just flare up?
Yeah, that's a really excellent question. So we have seen people get immune to it, and FDA just approved treatment for people that have recovered from it. So we do have cases that are recovered, and we're going to start giving blood to the or really antibodies from those patients to the ones that are really, really sick. So we haven't seen we haven't seen it behave like herpes, but it's like flu, right? So flu has a season, right? It's seasonal almost. And we don't know that this is going to be seasonal just yet, because we haven't seen a summer. But it's like, just because I got flu this year, that doesn't mean I will not get flu next year. I could get flu again. So I think that's where the example is. It's not, herpes is different. You get the same virus, you always have it, and then stress will, cause an outbreak again. But it's not that. You can get re-exposed to someone, just like I said, right? So if I got exposed to someone 2 weeks ago, I didn't develop symptoms, I'm out of that incubation period this one time, but I could get exposed to someone else again, and then this time I might catch it.
Right.
It's the same thing. So next year, next winter, I might get exposed to someone again, and I might catch it again. Now, the idea is that your body's immune system will be able to handle it better, right? That's the whole idea of a vaccine, essentially, is to training your body to get ready for this enemy.
Right. Okay. Got another question. Does COVID-19 have many subtypes? I mean, why is it more aggressive and killing more people in Italy than in Germany, for example, or other parts of the world?
Yeah, another really good question. So there is no different subtypes. It is a type of coronavirus, but COVID-19 is COVID-19. COVID-19 doesn't have many subtypes. Now, coronavirus has different subtypes. So COVID-19 is a type of coronavirus, which is a subtype. Why it's more aggressive? So there are a lot of theories going out, and again, not pure science, right? So I'm just throwing out, and this is from experts, right? So from what my infectious disease experts have said and my epidemiologists have said, is a couple of reasons. Italy, where we're seeing the outbreak, the epicenters, there are usually older retirees there, and then also if you look at the population density in Italy is really high. So Italy is a really small country, but the density is almost, I think, 30 times what it is in US. So people live very closely. Also, the Italian sort of family structure is living in large families, coming together, dinner, etc. So just their lifestyle, it's a lot more socializing and being close to each other. And then the other theory is that there were a lot of Chinese tourists in Italy as well. Not just Chinese. Italy is a really hot travel spot, right? Vacation area. Actually, I was thinking about going to Italy as well. So a lot of people go to Italy. Nice weather. Again, a lot of shopping, a lot of good food, a lot of good nature. So huge tourist spot, a lot of elderly, and the family structure is just it's just ripe for a outbreak, right? Just same thing as New York, right? Really dense city, huge international travel, right? A lot of large airports, three large airports, a lot of international tourists coming through, and a lot of people living in very really small compact apartments and things like that. So
Um, so one of the things that I read was that a thing that China did was that once somebody seemed like they were sick, instead of letting them go back home, they were quarantining them in like tents and things like that, completely outside of the home. And that is what they're recommending that both Italy and the US and like basically every other country should do. Is that something that we're potentially looking at, is quarantine outside of our homes for people who are maybe sick?
yeah, I've seen some chatter around that. It's just I think people might not be as good of at quarantining themselves as we think. Um, so we if in areas that have become really um, big epicenters like New York, that might be something that's coming down. Basically, the people that are sick, even mildly sick, might need to be quarantined for 2 weeks. Not in hospitals. You don't need to be in hospital to be quarantined, but sort of a dorm or just hotel or something until they get better.
Okay. Got another question. Are you treating infected people that don't have health insurance, or are they turned away?
Wait, what's the question?
Are you treating infected people that don't have health insurance, or are they turned away?
Oh, that's a really good question. So, as part of a community organization, a nonprofit organization, we are uh, it's our duty to treat everyone regardless of their insurance status. So we are treating everyone, and we're actually going above and beyond just that, even with those that have insurance. So, for example, we just removed for telemedicine. We removed our copay and deductible requirements up front, which we normally charge. So even when you have insurance, there's always a copay or like a deductible that you have to pay, whether it's $10 for a PCP or a specialist. But we removed that up front, so that trying to make it easier to access, and then we'll just bill them after the fact. If it turns out to be something that they really needed care for, then we would bill them later. But we're not collecting anything up front, so the patients are not having to pay to get care. So we're removing a lot of barriers to access care, and even if someone doesn't have insurance, we'll definitely treat them.
Okay, cool. Let's see. I don't know if this is state by state or like system by system, but who can get tested? Is that just obviously not everybody, because we know that one of the issues is that not everyone can get tested. So who can get tested?
Yeah, so the testing guidelines change constantly. We definitely That was one of the things we have realized, and I think I can say this because CDC has come out and said it as well, that they really sort of screwed up on testing initially. They had the really narrow testing requirements, and they have opened it up since then. So currently, we're testing patients that have symptoms, that have coronavirus-like symptoms, with or without exposure. So if they don't have, of course, if they have flu, then we won't test them. But if they have, if we basically a physician that has a suspicion, we can order it, which is really, really greatly changed and improved markedly, because up until like just week or 2 weeks ago, CDC or the health departments wouldn't allow us to test. Now, of course, things have also changed, is because we've developed our own test. So we're testing in our own labs. We don't have to send it to CDC or health department. So the health department just didn't have enough tests to go around. So they had really strict criteria. but now it's opened up. So anyone that we feel is a suspicion, as in we don't find a cause for their illness, whether it's flu or some other something, then if you get an evaluation by physician, you can get tested. And the other I guess criteria is for healthcare workers, which is a little bit different, and I don't want to get into it because I don't know how many docs are on, but we have changed our criteria for basically healthcare workers who are exposed. We are testing them as well, so that's changed a little bit.
Okay, and is that just the system, or is that happening nationwide?
I think that's a lot of systems are going that way, but it's if a system and again, we're unique because we're so large and we have our own tests. Not everybody has that capability or capacity to do, but I know large systems are testing their healthcare workers, so it's not nationwide for sure.
Okay. Got another question here from Shadana. If an undocumented person comes to get tested, does the hospital call ICE?
Oh, that's a good question. We hospitals don't normally call ICE to begin with, and I can sort of validate that as well because we run a free community clinic, and my hospital system provides services to our free clinic in terms of lab and diagnostics, and we don't ask for immigration status.
Okay. And do you have any policies that prevent any of your workers from reporting to ICE?
It's not in policy expert, but I would have to check on that. I would not think we would have a policy. We have policies on what to do, not so much policies on things like that, if that makes any sense. Yeah.
Sure. You should probably
Again, we don't even ask immigration status, so that's something an employee wouldn't know about a patient.
Sure.
Yeah.
Okay. Let's see. Just have a few more questions because this will cut us off exactly an hour in, so we only have about 10 or 15 minutes left.
Okay.
Do you think there's things that could have been done to prevent like the pandemic and how it is sort of unfolding in the U.S.?
Yeah, it's a really good question, right? And hindsight is 2020, and this is not over yet, right? So there will be books, papers, tons of things written about this to answer that question. And I'm still, we're still in the middle of this, right? Like I don't think we reached the peak yet. And this answer will probably change. But public health will definitely be a much, much larger focus as it's never been before. I'm not saying public health hasn't been a focus, but it's not as much focused on in this country and around the world, really. Probably who will take more powerful role in that. CDC will, and FDAs and things like that. I think we as a nation need to prepare more for such pandemics. Bill Gates and his foundation has been sort of talking about this, vaccines and things like that, because we've seen this now. We had SARS and we had MERS and we have no COVID. Between that we had Ebola as well. So they're coming. They're coming in waves. They're definitely not every year, but there have been a lot of outbreaks, and I think the connected world, the travel, and how quickly people can get from places to places is making it a lot easier to spread, and not just spread, but spread it really quickly. which we've never seen in the history of the entire humankind, right? Like the Spanish flu virus that killed a lot of people, but there was no travel. We were just joking the other day, right? Like, so if you were coming from Spain to US in 20s, even if you were infected by it, you probably die on your journey over the Atlantic before you reached US. So hopefully you didn't bring the disease with you, but it's not the case anymore, right? Like, I can fly from Spain to New York in like 7 hours. So by the time someone is even showing symptoms, they probably would have arrived here. So it's going to be. I think we will definitely come out of this experience. I'm hoping in a whole different world. I can sense it, and I know our health system has changed. My health system has changed, and it has changed others around the country as well. So just like I mentioned, we've gone 900% increase in telemedicine. A lot of people are going to access their doctors and their providers this way, and it's not just us; it's everybody's seen the same way. I don't think people are going to go away from washing hands as much as we are now, right? That's something that's like will probably remain ingrained. Some of the social distancing, I think, like handshakes, I think that those will probably become outdated, maybe. A lot of like Zoom work and things like that, right? Like people doing remote work, online work. A lot of companies, a lot of businesses are going to question that. Online schooling, I think, will also probably play a part a little bit into it. But I think the world, the humanity, and the health systems are going to be changed from this experience, and I'm hoping that in itself will prepare us a little bit more for another outbreak like this. And I don't think this is the last one, unfortunately. There will be more.
We have another question. Can we get a false negative test, and what's the main reason for that?
Yeah, so false negative. So false negative is so any test, right? It's not 100%. Is 100%, right? So you're gonna have false negatives and you're gonna have false positives, right? We try to make our test as accurate as possible, right? Which is 99% sensitivity and 99% specificity, and we're pretty up there with our tests. But any test have issues with. So that's the reason why you would get a false negative. The other reasons might be viral loads, and we haven't even gotten there. Of that, and so that's just a test, right? So test itself is not, any test doesn't have 100% accuracy. It will have some level of issues inherently, but the timing of the testing is also important. Also, I'm hearing the test itself. So we're doing nasopharyngeal swab, which requires really going in, right, with the swab, going inside, not pen, but it's like it's a swab, right? So it's like a stick with cotton on it, and really going up in there in your nose and getting your nasal pharyngeal cells, not just like rubbing, but really going in.
Go into your brain though?
No, I don't. No, I don't think it. Those are large. So this this is pretty big. It can't go up to your brain, but the test, how you do the test or how you perform the test is also an issue. So if you didn't get enough virus cells or you didn't go up far enough, you could also get a false negative. So just the performance of the test can also cause issues. And then sampling, right? So you have to, most of these tests, like I said, we have our tests here. Most of them are done at commercial labs. So LabCorp was doing it in California. So sending from East Coast to West Coast, it takes a couple of days. I mean, we take proper precautions. It's put in cold temperature, cases and things like that. But, again, it's only human, and transportation can cause issues of the samples as well. So the samples can get sort of not be good just from transporting.
Okay. So we have a few minutes left, and if anybody has any questions, they can put them on to the live thing. But a few comments that I got when I did the story earlier, or I guess yesterday, people are thanking you, and they want to know, how are you doing? How's your mental health? How's the mental health of people who, are on the front lines of this? What do you think?
Yeah, so it's a lot. Like I said, we have been going at like 100 miles an hour for every day for over a month now. Crisis leadership is different. Practicing medicine in a crisis is very different. Some of us have been through this before in variety of ways. And I've seen, I've of course practiced here, but I practiced medicine in other parts of the world. So I have a pretty good grasp of how to sort of navigate a system in a crisis situation where you don't have all the resources. We've had people who've had breakdowns, and we've had people who are really scared and who are really nervous, right? Because we're all humans at the end of the day, right? So no matter what, just because I'm a doctor or just because I'm a leader, that doesn't mean I'm not human, and that doesn't mean I don't feel how bad this will be or how bad this could get. So we've had, we of course have our mental health colleagues that are helping us guide through this day by day. Some of the things that can be used really by anyone is just trying to stay off news, trying to stay off social media. And it's hard, right? Because when you're sitting at home, that's what you have. And if you can't stay off, pick a day or time when you do get news or when you do get on social media. So, with some things that we have been recommending is that, maybe when your governor is giving a news conference, pick that time to check your news instead of just constantly checking news throughout the day, because that alone can cause anxiety. Same thing for social media, right? Like you see a ton of stuff on social media as well. So pick a day or pick a, reliable trust. I've seen, and we have seen, hit by a lot of fake news, and fake news sort of based off our hospital systems, like, oh, UPMC has this many patients or has positive patients, when we didn't really have positive patients. So a lot of people causing panic, using our names, using our and not just our names, other health system names, and spreading fake news. So making sure, trusting your sources. But yeah, so, and then of course, just self-care, sleeping, working out. I like to run. So taking that time to turn off things. And it's a lot, right? Because like I said, I basically start every day, like 6 o'clock, emails, text messages, phone calls, till the time we sleep. But taking off that time and just recharging is so important, and that helps me sort of get through day by day.
Right. Oh, yeah. All right. So I think this is one of your followers. His Dr. Salim got tested or not?
Oh gosh, who's asking that question? So,
Sharabi.
oh, he's okay. He's my student actually, so he will have to talk to me. So no, I have I haven't been exposed, and the patients I've seen, I've always had my PPE on, so I put N95 and then I put my eye shield mask. So there isn't a reason for me to be tested. If I get exposed and or I develop symptoms, then that might change things. But I'm not in that category yet, so haven't been tested.
Okay. All right. Well, thank you for all of this information. We're going to get cut off here soon. Any final thoughts or anything that people can do to get help or to be helpful to healthcare workers at this time?
So that's a really good question to end on. So definitely stay at home. Practice social distancing. Take this really seriously. This is a pandemic. This is not a drill, or this is not a joke, or we're not scaring you just because we like to. This is the real deal. I've seen young people, I've seen patients without any symptoms be really sick from this and die from this. So take this seriously. I know it's rough. I know practicing social distancing is not easy. Being stuck at home or away from your friends, family, coworkers, school, it's not easy. But this is the best thing you can do for now. And how to help us it's basically, this is the best way you can help us help you. Soon we will be announcing, and you guys can either follow me or go to Zamzam, which is a nonprofit and I work very closely with, on how you can help the healthcare workers. So really exciting project that we're looking forward to announce I think it's being announced today, but I'm taking over their social media tomorrow. So if anybody's interested in hearing or learning about that, they certainly can, on how to basically help us.
Okay. Well, thank you very much. That was super informative. I'm surprised we were able to get it all in an hour. And thanks to everybody who was watching and had some really good questions. And thanks for taking time out of your day. Tell your people that we appreciate them, and happy National Doctors Day.
Thank you again. Thanks for the opportunity. And they can still send us questions. Happy to answer them. So.
Okay. Yeah, and I can't tag you on this, but if you go to my story, you were tagged. People can find you and slide into those DMs.
Awesome.
All right. Thank you.
Bye.